Hey, Daniel, how's it going?
It's good. It's been a crazy day. I actually bought a car today, which is always super fun and exciting, a little stressful. How about you?
It is crazy. It's kind of a busy day, just working on projects, no car buying here. What type of car did you get?
We got some old Volkswagen like Golf. It's like a super, just a nice car to get around town.
Nice. All right. It's like the Tesla. Everybody I know is buying the Tesla right now. I'm like, maybe it's on the list. We need to buy Matt a car at some point. So, all right. Well, this is episode 5 for our new listeners. We just came off of kind of the great 2-part episode on the debate between Rev Cycle and IT. We called it the Smackdown, and those guests have agreed to come back. So look for a reoccurring guest theme spot in season 2. We will be featuring that segment again. All right. So this episode is going to focus on the front end and of revenue cycle, and we'll start to mix up the space a little bit more as we progress throughout future episodes.
Yeah, we've been doing a lot of prep for this one. Lots of questions. I think today is going to be packed. So let's make sure we just get started right away. Have time for our 2 guests here today. And let's just jump right into our Hot Topic segment.
Perfect. All right. Well, welcome to Hot Topics, everybody. Today we have 2 amazing guests joining us. It's my pleasure to introduce our first guest. He is an accomplished executive specializing in IT startups and spinoffs, business development, partnership, strategic marketing, sales, healthcare technology, and software solutions. He's the founding member of 2 successful healthcare IT companies focusing on improving systems and services to provide healthcare communication management. With over 25 years of experience in healthcare IT, it's my pleasure to welcome the Chief Business Officer of Vyne Medical, Scott Overholt. Hey, Scott, welcome.
Appreciate it, Evan. Thank you very much. And Daniel, it's great to be here. You know, anytime you get an opportunity to work with Patti Consolver, it's a good thing, especially when you're talking about the front end of revenue cycle. So excited about our topics today, excited to be here, and look forward to the discussion.
Thanks, Scott. Yeah, I have the honor to introduce our second guest, Patti Consolver. Yeah, we started together pretty recently at the same time at Wilshire. And Patti is our Director of Business and Development with nearly 30 years in the revenue cycle. Recently won the Marion Blankmanship Award from NAHAM. So congratulations on that. And obviously a leading expert in the space, in the healthcare and patient access space. Welcome, Patti.
Hey, thanks, Daniel. Yep, we did. We started the same week. We were mentor buddies together. So yeah, I'm glad to do this podcast with you, Daniel and Evan. Thanks.
Well, welcome. So Patti, you were sharing with us just recently and just saw a presentation at NAHAM that I think you and Scott actually were on a panel recently together as well, talking about the changes that have occurred in the market and concepts and how organizations are kind of having to flip and change their business. So we thought for this Hot Topic segment that we would kind of learn more about what's happening in the patient access and front end space and hear both of yours and Scott's take on it. And then in a little later segment, we'll learn more about actually Vyne Medical.
Yeah, there were tons of new ideas out there at the NAHAM conference. Really good ideas. I think folks had, COVID really forced folks to really think outside the box and come up with some, solutions that we didn't think of before. Technology was in place for us to really partner with vendors and come up with ideas that would allow us to do things we probably wouldn't have thought of before on our own. One of the things that was really kind of just really out there was a virtual teleporting type concept, much more than just the typical kiosk, mobile check-in type concept. It was allowing us to, or allowing this hospital system the capability to bring their staffing together wherever they were, whether it was at home or in a remote area of the hospital, but they were able to just really register patients wherever they were and teleport them to another area. So if it was a small rural hospital, they could just register in one area of the hospital, all their patients, 5 miles down the road or wherever. It was just kind of a neat concept. And I think Vyne kind of has that same similar concept kind of in play today. So Scott, you might be able to talk about it a little bit more than what I'm kind of explaining, but it was just kind of a neat idea because it was the patient could pre-register ahead of time, all electronically. So you never had to talk to anybody on the phone. So it was, you did it through the My Chart portal, through Epic, then did all the signatures, the payment, everything was electronic. Then the patient came in and then this whole teleporting capability happened. So Scott, what exactly was that we saw?
Yeah, Mayhem was super interesting this year. As Patti said, a lot of innovation. And, you've got a lot of dynamics that are happening in the market, right? You've got the whole marketplace coming out of COVID. If you look at the statistics, hospitals are really struggling right now. Margins are way down, even to lower than pre-pandemic conditions. And really, some of the struggles that we're seeing are not only our margins down, but also the personnel, the human resource, and the staffing struggles that hospitals continue to face seem to be driving a lot of this. A lot of this activity, a lot of this innovation, a lot of this, how can we do more with less? And what Patti was talking about is, the concept of, engaging patients, remotely, right? So it starts with the self-registration, which, allows the patient to actually take the responsibility of registration through an electronic system that's remote. There are some offshoots of that we're also working on that are cool, and it's very much in line with what Patti was talking about, in that there are situations where patients need assistance, right? So a completely, totally, virtual experience won't cut it, and they need help from a coach, from a registrar, whatever it might be. So we're working on technology, a concept right now, for lack of a better word, called teleregistration, that allows basically a remote coach to appear on the screen to help a patient through their registration. A perfect example, and we've seen this at HCA emergency departments, is one place that we know that it's been deployed, where you have a normal in-person bedside registration that has an in-person coach, right? And this is now able to be replaced by a remote, virtual, live person to help them walk through the steps, the document review, the image capture of their ID cards and insurance cards, to be able to capture electronic signature, remotely from an iPad or a tablet, to be able to process payments right there from that same device, all with the help of a coach. So that's one of the things that we saw at NAHAM that was, a new concept that's being driven by the economics of the day and just the situation that hospitals are facing.
Why it was kind of interesting for me was because, from a management perspective, when someone called out sick, you had to scramble and try to find somebody to, call in and have them, get dressed, come in and provide that coverage. Whereas here, the example they gave is, well, no, what you can do is just teleport that person to that site. And now you're providing someone coverage from a remote location in another area of the hospital. And it was mind blowing. It's like, wow, this is pretty cool. You're able to cover more areas of the hospital with less staff. We were thinking more, in line of remote pre-registration and remote this and remote that, but it was never on my radar to say remote registration, that wasn't there. And so that was kind of neat for me.
Takes it from being pre to actual live registration.
Yeah.
So like patient in the ED, they have COVID-like symptoms. You're leaving a wow in the room and you just remotely pop up on the screen and you're like, how are you doing? And start interacting. So I think that's cool. Does it pick up where where the patient left off? So like say I was pre-registering through my chart and I didn't get it done, but I don't want to have all those same questions again when I come back in. So it already knows. Very cool.
It was integrated with Epic and the Hello system, Hello and all those pieces. So yeah, it was great. Right.
Sounds like it was a very interesting conference. For some of our listeners like myself and Daniel, who, I've had a little bit of the front end in my career from leadership perspective, but can you guys give a little bit about background about what NAHAM is and how you guys got involved and how it partners with the front end?
Sure. NAHAM is the National Association for Healthcare Access Managers. It's been around for a very long time. I've been on the board for about 25 years. I've been in a lot of the different positions. I've been a past president, past membership chair. My most recent position was the executive delegate position, which I oversaw the delegate regions, those type of positions. It's a great networking opportunity. I love collaboration. Anybody that has ever worked with me knows that I love to collaborate, love to share ideas, share information. I think we're only as good as the information sharing that we get from each other. And so just the networking is just unbelievable. If why reinvent the wheel when you can share it? And it's just great. And then going to those conferences is great as well. And so COVID was awful because, you couldn't go to those conferences and meet with everybody. And so just getting back together. And again, this last year was just great, this last conference. But yeah, NAHAM is just like NARI and everybody else, the other conferences, but it's a good opportunity to get with everybody and just collaborate.
Yeah, my thoughts there are, it is a fantastic organization. Our companies have been involved in NAHAM for, I guess, over 15, maybe 20 years. And there is no better place in healthcare if you want to be with the people on the front end of revenue cycle that are making things happen, that are innovating, and that are dealing with challenges that they face. There's no better place than a NAHAM conference.
And what type of people go to NAHAM? Is it really just like folks in hospitals and vendors, or is there a broader group?
Yeah, it's all the front end patient access folks. It's definitely your leaders in front end patient access. We've got the certification classes with the certification, the CHA and the CHAM, Certified Healthcare Access Manager and Associate certifications, and so anybody on the front end goes to those.
Very cool. Thanks for giving a little bit of background for our listeners. Future episode, everybody, we actually have the NAHAM current leadership joining us as well. So to dive in a little bit more of how they're partnering. But speaking of partnership, I mean, I know that you both have had the pleasure of speaking together and also working together on projects and implementation. And since we're talking about advancement here in the front end of the space, how is it taking from with even COVID change, looking at moving to this, virtual patient access person, how's the rest of it expanding outside of just even like the hospital setting, looking at it from a clinic or an ambulatory type setting as well, are they leveraging the same type of technologies and implementations, or are they trying to do their own spin-off and kind of set a clinic aside, being able to provide wait times and things of that nature at the same time?
Yeah, go ahead, Scott. I think I've seen, definitely seen the same type of momentum happening with the clinical staff, especially with orders faxed orders going into scheduling and the like there. But Scott, you probably see it more so than I have.
Yeah, I was going to say that there was a movement that was beginning before COVID for revenue cycle employees to begin to work from home. Actually, Patti is one of the industry's pioneers years before COVID came. I know that Texas Health Resources had 500 employees that could access our solutions that were working from home, at least part-time. And we were beginning to see that movement across the country. There were a couple drivers that were causing it. One was as hospitals began to consolidate, right, and space became a premium. Health systems had a decision to make. Do they buy, do they build, do they rent, or do they consider a work from home program? As the thought leaders in the industry began to push that way, those hospitals facing those decisions began to take note and take action. So there was, we had documented over 1,000 hospital employees just using our systems alone years before COVID, and it was beginning to be a movement. Then you had COVID come, right? And all of a sudden it was just like this mass exodus where it was a requirement, put a huge amount of stress on hospital IT departments, on HR departments, and on the individual departments themselves in revenue cycle and in other areas. It's very interesting with the labor challenges that hospitals face today. Work from home has become a benefit for them, right? And it has given them a larger workforce and a more available workforce to choose from. We are specifically, Evan, getting to your question, we are seeing some of the same from the clinics and the surgery centers, et cetera, especially those that are owned by hospitals, right? Because they've got the infrastructure, they've got the consolidation, they've got the teams to be able to push them home. They've got the scalability, they've got the systems in place, et cetera. So we're definitely seeing that happen.
The issue is the folks that were not as prepared when COVID hit is that they sent the folks home thinking that, it would be easy to send them home without having that foundation in place. And so now that they've sent them home, they've had to backpedal and make sure that they've got the policies and procedures in place. They've got the infrastructure in place to make sure that they can sustain what they've started now that they've got them at home, because the metrics are there. They've proven that you can work from home, but we've got to make sure we've got that infrastructure, that it's in place, that they can sustain that durability there.
Yes.
Were there any things that you tried to transition to an at-home environment that just didn't work, or that we were trying to spearhead and just found that there is some need for in-person, or was everything a successful transition eventually?
No, I think there were things that you really needed to have, you needed to have it in person. Like, I know there were some things in the billing office, like with mail correspondence, you definitely couldn't do that from home. So there were things that you had to find, well, how do I do that in person? There's things that the patient still needed some of that touchy-feely stuff. So we needed to have some financial clearance type folks back at the hospital. But the pre-registration definitely, and the insurance verification staff could work from home. That was not an issue at all.
So I know, coming back from an operations background as well. So I was over insurance verification and pre-reg, and we had a core team. We were moving to work from home. I mean, our primary estimators were able to work from home already. That was kind of routine. Pre-reg, hit or miss. I mean, we always staffed one person in our pre-reg department to be on site so that they could pick up the printed things that needed to print. Somebody needed a hard copy of that receipt that they paid for their point of care service payment or upfront copay portion, and we didn't have a centralized mailroom. That was like my big push, like, hey, we got to figure out how to do this so we're not having, everything go to each floor to pray, including claims and things of that nature. But for pre-reg, how did it work for doing, like, I don't know, my pre-reg department and insurance verification department dual covered, so we could split staff between the two departments as needed. But somebody always had to be on site to fax. They had to fax the daily census to those insurance companies who would not take an electronic notification of admission, right? So how did you conquer that, or were you able to figure out how to remotely do it?
We remote fax through Vyne, through Vyne and Write Fax. So that was all done through the computer system. So that was not an issue at all.
Oh, nice. Okay. So that is, one of the technology components, I think, that, definitely getting into a future segment here to cover, because I think a lot of organizations, I know when we were reaching out through HFMA and other, groups, nobody knew how they were doing that, especially they were all looking at solutions there, but nobody had implemented it pre-COVID. So everybody I had a team of 2 that sat, a complete opposite side of the floor during COVID, so that they could use it, and had dedicated fax machines for that kiosk space for them. So I think that's one of the components. I know we struggled as well when we look at remote or looking at virtual assistants with, self-kiosk components, keeping them clean, keeping them sanitized, and COVID brought that even more in a highlight. Patti, how has others through NAHAM talked through those and shared their instances from an operation experience? And then Scott, from a technology experience, what have you seen your company and other companies starting to roll out to assist with, kind of that patient experience, and then also that preventing additional cross-contamination infections?
I've seen lots of different presentations on the kiosks, and different hospitals have had different outcomes with the kiosks, and really it's how well your upper leadership has pushed that kiosk experience and supported that rollout. If you've got a good backing and support system behind your process, I think you'll see good results. But it goes with anything that you roll out. If you stay on it and work towards that metric, then you're going to get those positive results. But if really you put it in place and you don't really monitor it, you don't really follow those metrics, then you're not going to see the results. But we've seen some where they've got high numbers, and you've got staff that sit there and they go through and they clean the machines after everybody, and you've got volunteers that are signed up to handle that, and they've got processes in place to really focus on that whole operational process. And you've got good numbers to support that, then you've got a good process in place. But then you've got others that really don't, and you've got the numbers that show that you don't really have a process in place. Hopefully that makes sense. But I saw that 5-10 years ago with palm vein scanning. Everybody was real excited about palm vein scanning, and I had we were going to roll it out. A hospital system down in Orlando had great numbers. They had hospital support system in place, and everybody loved it, and but when we tried to roll it out, we just didn't see the same numbers because we just didn't have that same push behind it. And so same thing's true with kiosks. You could have hospital A who really loves the kiosks, and hospital B doesn't, and you'll see the same don't see the same results. So
yeah, I think even larger healthcare organizations, right, are seeing that amongst their own hospitals, or geographic regions that they're serving within those hospitals, within their areas too. Like rural areas, not so much adoption of it, even adoption of my chart accounts and things of that nature, comparison to more metropolitan areas. So,
but to answer your question, I've seen some have their volunteers have some type of a schedule that after every second person, they go in and have a cleaning process in place, or some type of protocol in place to make sure that the tablets are clean or the kiosks are cleaned out, and just whatever process works with it, for that process. But
yeah, and then Evan, about your technology in question there, for the remote staff, what we found the keys were is giving the remote staff the ability to be entirely paperless. So nothing needs to be printed, nothing needs to be handled. So like, for example, electronic fax or electronic interface with another system, all that needed to be paperless. No, they couldn't print from home, right? Because PHI and all that. Second big thing was giving management the ability to be able to monitor everything, their performance, their throughput, their productivity, everything, remotely. So it didn't matter if the team was in the office, half the team maybe was in the office, half the team was maybe at home. They could monitor their performance and productivity just as if they were in the office. So those were the two big components: paperless, secure, and then the ability to monitor.
Well, we are at that mark to take a quick break, and we will be right back.
Claim Capital is a team of ex-Epic staff focused on preventing denials. Instead of showing what was denied, which is the standard for other solutions available today, Claim Capital pinpoints why claims are denied. By training machine learning models on an organization's claim and remittance data, Claim Capital can identify the causes of denials and recommend changes in EHR build or workflows to prevent them from happening in the future. With a completely HIPAA-compliant infrastructure, no software implementations, and a zero-risk pricing structure, organizations can quickly and safely recover lost revenue.
And we're back.
All right, time for my favorite segment. And this segment is the debate. And we're going to discuss all sorts of things. Traditionally, this covers industry trends, out-of-the-box ideas, or topics that get you thinking. And I think today we have a special one, Evan.
Yeah. So, hey, Scott, as we're just wrapping up the conversation about NAHAM and kind of what you guys were seeing in the industry and where things are headed, we want to continue the conversation about automation and see how Vyne Medical is leading in this space and learn more about you.
Okay, great. Thank you, Evan. The Vyne Medical's focus is all about helping our clients really deal with those two situations that we talked about to begin with, right? Pressure on margins and staffing challenges that they face. Obviously, work from home, remote work is one way to deal with it, right? That solves at least a portion of the personnel issues. But another way is through automation. And our company spends a lot of time, today we have 800 hospitals and health system clients, but we also have a lot of prospects and partners in the market. And we spend a ton of time in patient access departments and other revenue cycle departments doing workflow assessments. That is basically looking at their workflow and looking for areas where there might be some improvement, might be some good ROI, might be an opportunity to start chiseling away a little bit at that margin deficit that they're all facing. Automation is a fantastic way to do that, and it is very prevalent where manual tasks reign in some of these departments. Everything from dealing with forms. So this could be a fax, it could be a PDF, but it's basically something where an agent at the hospital has to look at a form and transcribe or index information off of that form manually. So they're looking at the form and they're basically typing in data from that form into a record that ultimately ends up in the EHR. Today's technology allows you to be able to automate a lot of that through, AI and ML or form recognition, other technologies that exist today. A lot of those transcription processes that are typically done manually can be automated. And they can be verified after automation or based on confidence levels they can just push on through. We have one client today that has taken the transcription of physician orders, and literally over 60% of them are 100% automated, never require a human touch. So that kind of leads to another automation that helps in the process, which is integration, right? Integrating this data with other systems. a lot of times when folks are pulling information off of forms, the next step that they have to do is then get that information and the image of the form over to the EHR. All that can be automated as well. So integration with other systems can help workflow downstream become now automated, build work lists, etc. There, if you keep going down the chain in patient access, another one is the outreach to patients, right? So today, if you walk into a lot of hospital patient access departments, there will be a team that will be manually reaching out to folks that have a procedure scheduled or another order to get these things scheduled, right? Well, with today's technology, not just auto dialers, but also text messaging, it's easier than ever before to automate that outreach, to engage the patient electronically on their own device, to give them options like, do you want to talk to somebody live, or do you want to go to our scheduling portal and do it yourself, right? So it gives us the ability to be able to not only automate that manual process, but then now we're engaged with the patient that can allow us to be able to automate the next step, which is, providing them an estimate and maybe even doing an upfront collection of their copay, right? All basically automated. So those are a couple ways. There's another one that's really interesting too, and it's voice analytics. You have a lot of verbal communication still going on in healthcare, right? And likely always will be going on. Financial counseling sessions, things like this, where, the patients need to talk to someone to understand what their options are, what their obligations are, and things like that. With the average hospital doing thousands of these conversations a day, it's difficult for management to be able to assess quality and compliance of these communications. But the tools exist today to be able to automate that analysis. I've got one really good example where we have a client who requires a specific phase during financial counseling at upfront collections. And she is able to run an automated query through those thousands of voice communications, whether they're face-to-face communications or phone communications, whether they were done, at the facility or done remotely. All of them can be analyzed, and then she can get a report back that provides her with compliance levels, and also identifies which agents may be struggling with the specific phrase that's required there.
Is it only, hey Scott, in that, that sounds intriguing. So do they have like a mic if I'm on site? Is it like a mic that's at their desk and it's just they hit a start button, or how does that work? I totally get like the phone component, right? But like, how does the in-person portion work?
There's a microphone at the PC level. It's on and it's driven by the keystroke on the PC. So when the registration starts, it starts recording. Yeah.
Oh, cool.
Let me give you an example. Let me give you an example too of something that helped me with from a leadership perspective. Is we had a chief medical officer that one time that had a concern, rightfully so, that the registration was not capturing the primary care physician correctly. And historically, you may not be able to prove that, yes, the staff were collecting primary care physician, but by capturing your patient journey, by recording that and also capturing this voice analytical piece, I was able to then run a report by capturing what percentage of the time was the staff asking that question, who is your primary care physician? And I was able to then substantiate my claim that yes, 98% of the time the staff were asking that question. And I wasn't asked that question again, because I was able to then satisfy that answer that I was able to, we were asking that question. So it's just great information to be able to have at your fingertips, to be able to say, hey, are we asking these questions? Are we asking the ethnicity? If we implement a new scripting, do the staff fully understand that scripting? And are they really, are they implementing what we asked them to implement? those type of things. So it's good to have that information.
I was going to say the compliance factor, it has to be absolutely just like staggering to be able to see firsthand and immediately are people being compliant with X, Y, or Z.
That's the huge ROI on it. Like even with the rollout of the No Surprise Act this last year, you could really go in and be able to pull that information and make sure that with the price transparency piece, that your staff were fully engaged and asking the right questions. They were following the scripting that they should have been following. You really were able to provide that information, and you were confident in those answers that you had. So yeah. I was fortunate to come from a system where we really did. We recorded that whole financial journey from the point of scheduling to the central billing office to the final bill. So it was great because you'd be able to go in and if there was a patient complaint, you'd be able to find out exactly where that opportunity existed in that stream. You know, did it happen in scheduling? Did it happen in pre-registration, registration, insurance verification? Where did the opportunity happen, exist? Because it was not only did we record it, it went to the patient record. So we were able to go into Epic and be able to pull that from that patient account because that's where it was saved. So it was great.
And Scott, you're a chief business officer, so you're probably up to your point earlier. You're always thinking about margins. When the context like a conversation with a client or they're thinking about this automation, where does that really drive home, or what kind of like brings a light bulb to these folks as they're thinking about margins and automation?
Yeah, there's as I mentioned before, there are a lot of tasks that require manual human effort today that can be automated. Hospitals are already so stressed with finding the people and finding the right people that every time they're able to automate, it opens up, that person to be able to do something that's more revenue generating, right? Or if they have a vacancy, maybe we can fill that vacancy with some automation. So ultimately, it improves performance and outcomes thereof, which often are financially related. And it lowers cost because the automation is much cheaper than human intervention. There's obviously still a lot of places where automation, where human intervention is required and needed and preferred, and this just gives hospitals the ability to put focus on those with their human resources.
Patti, speaking of that, how did your corporate compliance team and legal team, guide operations from a standpoint of, okay, now we're recording messages, because I could see from an operational standpoint, like the fear of these being, able to be accessed if somebody did say something offensive or what it might be. I mean, of course, you're like scrubbing and you're looking for those instances as well to provide coaching and mentorship. But, how did they cover it? And then on the flip side, how did you get your team to be comfortable with this analogy and concept of Big Brother, constantly watching and hearing and seeing?
Yeah, those are some really good questions. And it was a big, all of it was a big ordeal. There was a lot of things that we learned from compliance. Definitely I'm trying to think what to take first, because there was a lot of good things that we learned from compliance. A positive that came out of the compliance piece. One thing, in patient access, I don't know if you remember, Evan, like whenever consent forms are signed and let's say a minor came in and you had to get 2 signatures because the minor came in, we never had to do that. We didn't have to do that anymore because they were recorded. So if you called the mom on the phone, you didn't have to go find a nurse to get that second signature because now you had it recorded. You just had to put the trace tracking number that was in Epic and have that signed and put the trace tracking number down. So that was a big win for us. So there were some wins that we would get out of this. So staff liked some of those wins. But some some drawbacks a little bit were that we could not, we had to put together definitely a policy in place, a compliance policy. So some things that we could not do is we could not email recordings because they could be sent wherever. So you couldn't just email a recording to this doctor because he wanted to listen to a recording, or to this department director because she wanted to listen to a recording. What we could do is come into a conference room together and listen to a recording together. So we minimized how many people could have security to this information. We safeguarded security and made sure that just those that needed to know, the need to know basis security measures were in place. So we had a very tight security policy around the compliance piece. Staff, we had to have a conversation. They signed a form that explained that all their conversations were recorded. Their personal conversations needed to take place on their personal cell phones that need to be happening, during their break times, lunch times, which needed to happen anyway. That didn't need to happen during, regular times when they're registering patients. So they understood that. And it was for their protection as well. And after a while, they really realized that it was really for their protection, because there were times, the majority of the times, it did protect them. If there was a patient complaint or a complaint from a physician or whatever, a lot of times it protected them. It came to their defense. So they liked it. The majority of the time it was a he said, she said, and it worked out in their favor because of that recording. So yeah, all the staff members signed a form saying that they were going to have to be recorded. Now, something that's different though in the state of Texas versus others, like in Florida and other states, some states have a recording regulation that both parties had to be aware of the recording. And so there's some hospital systems that had to inform the patient that they were recording. That's why when you call, you'll hear like a message saying that, your phone may be recorded for training purposes or whatever. In the state of Texas, only one person has to be aware of the recording. So we did not have to inform patients that they were being recorded. So we did not have anything notifying the patient on the desks like a hospital system may have that. I think Scott may be able to tell us of some of the hospital systems that have that, but I do know that there are some hospital systems that have shared that they've got notices and whatnot saying that they're recording. But hopefully that answers your question, Evan.
Yeah, it does. I mean, I know in Oregon, only one party needs to be privy to the recording, and that could be the person doing the recording as well. So I think, for my state as well, I mean, it would be easier to do and not have patients concerned. But there are times that I would have loved to have that technology as a director with the patient complaint to be like, okay.
Yeah, but just safeguarding the information. It was really interesting too, because the way this really started was, recording our insurance verification calls with the payer, and making sure that the payer information was, what they authorized was what they paid, and being able to overturn denials, that type of thing. And then we were able to branch out into pre-registration and scheduling and that type of thing. But then we started using these in call labs with staff. And, if I wanted to bring to the attention of a staff member, hey, listen to this call and see what your thoughts are with this call. First of all, the staff member would probably get on the defensive because, I'm bringing something to their attention and they don't really want to hear it. But when you go into a call lab with their peers and let them listen to it and they all start, analyzing the call and take the supervisor out of it, it's much more effective. They all start analyzing the call themselves and they really start understanding what they did that they should have done differently. And it was much more impactful. And made a bigger difference to the outcomes. It really did. And so those call labs became much more effective. And we did those more often. We would always have a positive and an opportunity call. And those were great. And the staff really seemed to like those.
Scott, how do you transition the technology also into being able to transfer patients out for them to do like their own credit card information, right? With all the payment components of the front end as well, having to collect patient payments, but needing to keep credit cards, confidential, where you can't record that because that is part of the federal statute. How does the technology work with that for our listeners?
Yeah, very good. Good question, Evan. So as far as recording a call, there are PCI compliance rules that state that you can't record, credit card information. We've worked really closely with the EHR vendors to be able to automate as much of this as possible. So, for example, if we have a user that's on an Epic screen making a upfront collection with a patient and the call is being recorded, as soon as they put their cursor in the credit card field, it automatically stops recording. So we have some automated ways to be able to deal with PCI compliance that take the burden off of the user to be able to to have to pause and resume where it's done automatically. If they're in a situation where, they don't have access to those types of systems, they can do a manual pause and resume there.
What's the regulation like in that industry and like keeping up with that? I know like Evan and I were working on something else with like CMS requirements that are coming out every year. It's burdensome for hospitals to have to like just go through thousands upon thousands of lines of new documentation. What does that look like for the PCI space and whatnot?
Just in general, that's one of the places where we can really help because we build those safeguards as much as we can into our software solutions. So, for example, if when you're dealing with CMS, you have a time limit, our software can start the clock for our users, and if it hasn't been satisfied, to be able to remind them that, hey, this is due or you're going to get dinged, right? So anywhere we can, Daniel, we'll put in safeguards like that as best as possible.
Yeah, that's really neat. I imagine that there's so much automation that's being requested by CMS these days that there isn't always a software solution, or the burden gets put on the patient if a hospital just goes really quickly to try to push something out. I can see there's definitely a benefit there.
Yeah, there really is. And, CMS has, over the last 10 years, has really expanded, for example, the ESMD program, which, in fact, this still happens a lot, where audit requests for supporting documentation and additional information for authorizations or denials would come in the mail, right, with a certain amount of time to be able to respond, and providers would respond by compiling all the documentation and mailing it back, right? All that over the last 10 years has become more electronic through the ESMD gateways. ADRs and the responses can now all be submitted electronically. And, we've got a huge amount of volume going through that electronically now too. It's just another, example of automation where, you're taking a super manual process and now making it at least a little more electronic.
What is one area, Scott, as people are thinking about, who might not have full automation? Because there are smaller health systems out there, even with COVID, like they didn't go 100% remote, or even be able to turn some of their teams remote because they couldn't afford the technology. But what is the one thing, as people look for moving more software integration in to help support workflows versus taking over full workflows for their areas, initially should start to consider when reaching out to a vendor like you, or even just internally starting the conversation?
Yeah, good question, Evan. I think our hottest one right now has to be with the whole form recognition and pulling information off of forms. if you look at the way orders, for example, are processed today, there's a significant number that are happening electronically, right? That could be through an Epic install that's been sent out to owned physicians or supporting physicians in the community, but there still is a significant volume that's not connected electronically, and it's due to many factors. Adoption is certainly one of them. Financial is another. Opposing, for lack of a better term, non-complementary systems, right, that don't talk. And in fact, because of the competitive nature of the systems, they're likely not to talk, right? And so you've still got a lot of forms that are coming in visually to the hospital, electronically most of the time nowadays, but still visual, and they require that transcription and that indexing. And that is one where it's an easy win, right? That is the first one that comes to mind, but taking it on down the line would be the integration of that data into the EHR, right? Just automating that process is an easy win for patient access departments. We've got now examples of bi-directional integration going back and forth with Epic to reconcile orders that come in where there's no patient that yet exists in Epic. That used to require some back-end manual reconciliation that we've been able to automate completely with Advent Health, which is a 51. This is fairly new, a 51 hospital system out of Orlando. So that's fairly new, but that saved a significant amount of time. So it's really the incoming process and then the integration with the EMR. And in Advent's situation, we're literally able to have the folks processing the next step, which is scheduling. They're scheduling off the exact same workflow in Epic, whether the order came in through Epic or whether it came in through a fax or another system. So that step, we're able to basically integrate the workflow of the electronic orders and the form, for lack of a better term, orders into the next step being just one single workflow. So that would be I think that's the hottest one right now as far as helping hospitals to automate.
Awesome. Well, we need to take another quick break, and we will be right back.
Vyne Medical serves a growing base of more than 800 active hospitals and health systems nationwide. Their best practices are hardwired through technology solutions, proven to help hospitals achieve sustainable top performance. Their well-published results include improving financial performance, physician and staff alignment, patient experience, compliance, and patient safety and quality measures. Learn more at vynemedical.com. That's VYNE medical.com.
And we're back.
Now it's time for the Wilshire Lab.
Yeah, and as we transition there, to give everybody an idea, in each episode we explore questions submitted by you, the listener. This week we have one question. And Scott, I just want to say thanks for that huge in-depth knowledge transfer there on where people should, might start considering initially in the patient access or even just in the paper realm of any part of revenue cycles. So we could bring you back again, I'm sure, to continue the conversation for future episodes. So let's transition over to that Wilshire Lab, Daniel.
All right. So our one question for today, I think we're probably sick and tired of hearing about this topic because it's been on our forefront for the last year. But now that we're implemented with price transparency, I'm curious, Scott, Patti, how have you all seen this help patients engage with their care? Like, what steps have we seen from price transparency just across the board?
I think they've become more informed for sure. They definitely become more informed. They're financially prepared. They research their payment options. They're able to select the right payment plan. They can make the determination whether they are going to have care or where they're going to have care. Prior to price transparency. They would have care, receive their EOB, and then find out how much it cost. And now they find that out prior to, and it eliminates that surprise. So so definitely they're more prepared to have the service today.
Yeah, I know. I like it when I know what I'm getting ready to spend before I spend it, right? For sure. And, you know, price transparency and the ability to share that information pre-care is, you know, it's almost like another step in that engagement, and another important part of that, the ability for us to engage patients electronically these days is super important, right? For all the reasons that we've talked about. But price transparency is definitely, you know, an important component of it, but it also builds trust, I think, with the patient and the family, and it builds trust in additional steps that engagement may have. You know, the following step may be a copay payment that happens, could happen right there online, or, you know, a follow-up scheduling visit, or, you know, a link to the patient portal to get whatever additional information they might need. So that the engagement portion of it really, it almost helps complete the picture of patient engagement, right?
And I'm excited to see where it goes as well. I remember when price transparency was first announced, people were scrambling for a solution, just like, what do I do? How can I set this up? And I think there was a lot of solutions that were made to just fit the requirements from CMS. And to your point, Scott, just like the idea of engaging with the patient and providing that full picture journey, I'm curious where that goes. If people will expand upon what the CMS requirement created to make something maybe a little bit more engaging and fun for the patient.
Yeah, it's been fun, you know, because there's a lot of data that's available that, you know, that we can help be the medium for communications with patients and with providers, right? So we don't provide any cost estimations, but we can certainly be the transporter of that information and make it easy for the patient to engage with it. And that's just one of many examples of that kind of data that's available these days that can be shared to further engage the patient.
I think it'll definitely be interesting to see and keep a pulse on how much is going to even impact the front end of revenue cycle across the board, more so, and how integrated health systems are going to have to figure out how to do better estimates and better transparency for all patients, even for non-employed physicians. I think that kind of becomes the big question, right? I know for myself, I just had a procedure done and got a $100 lab cost, and I'm like, wait, I'm in network for where my services were at. Why are you charging me an out-of-network price for a pathology report? And technically you can't. So now I had to know, but if I'm not an informed consumer of knowing what the regulations are, most people are just going to pay that $100 pathology report. So I think it'll be interesting to see how more we get out the communication, and then how health systems are going to become probably responsible for even auditing their out-of-network provider groups that they're contracted with to make sure that they're processing claims appropriately to the patients that they're serving. So,
Yep, good point.
All right, well, that is it for us today. Daniel, any final thoughts?
No, I come from a billing background, but it's always exciting to hear about the front end. And I know that we're talking about automation a lot today. And so hopefully maybe we'll get some questions come in that we can talk about on an upcoming podcast.
Absolutely. Well, Scott and Patti, thanks for joining us. Do you guys want to plug how people can get in contact with you?
Well, definitely they can email me at the Wilshire Group, p.consolver@thewilshiregroup.net. Definitely you can reach out to our LinkedIn, the WilshireGroup.net LinkedIn.
Yep. And if you'd like to contact me at scott.overholt@Vyne, it's VYNE, corp.com. And you can find us also on LinkedIn and on Twitter and even on Facebook. So look forward to hearing from everybody.
Perfect. Well, Daniel, Patti, and Scott, I think that's a wrap for us today. Bye-bye.
If you liked today's episode, continue to join Wilshire Wednesdays.
You can follow us on LinkedIn or find us on Twitter at Evan_Wilshire. Daniel can be found at Daniel_TWG. The Wilshire Group is at TWG Health. For us on Facebook at the Wilshire Group or on our Instagram at Wilshire IT Revcast.
Remember, if you prefer to watch, come check us out on YouTube at the Wilshire IT Revcast YouTube channel.
If you have an inquiry, want to share your thoughts, or get additional information on a topic, email us at thewilshirePodcast@thewilshiregroup.net.
The best way for you to support this podcast is to rate, review, and subscribe. We'll see you next time.
Bye-bye.
The Wilshire IT Revcast is hosted, produced, and engineered by Evan Martin and Daniel Bianchini. It is executive produced by Gretchen Case, Hank Smither, and Spencer Thielman. The Wilshire Group. Experience you can trust, results you can count on.